Welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults through our content that informs, community that inspires, and courses that deliver.
Hey y'all, welcome to Home Health Recharge. Today we talk about interdisciplinary med management and home health. This is part one of 2 parts, so please to sit back, relax, and enjoy the discussion. Hey everybody, and welcome to Home Health Recharge. This is Troy Mead here. Welcome, and today I have 3 different guests with me today to talk about med management. So in the new world of the patient-driven grouper model, we're going to look at some of the different ways that therapists attribute to the patient's outcomes that are outside of those outcome measures that we typically think of as like gait and dressing and grooming and everything like that. And today we're going to look at med management, more particularly at M2020 in the OASIS, that is the Independence in Oral Meds. So first off, I'd like to introduce my three guests. I have Celeste here with me. Celeste, can you introduce yourself?
Hey there, I'm Celeste. I'm a physical therapist. Do you want to know more?
I think we all know from the group who you are. If you don't know Celeste by now, then you haven't been paying attention, I don't think. And I have Lisa here. Lisa, can you introduce yourself for us, please?
Hi, I'm Lisa. I'm an occupational therapist. I know we're talking about home care today, or in the home care setting. So my background is in hospice and home care, and I've been doing some work in a skilled rehab for the last 5-6 years. So that's me.
Well-rounded, different experiences as well. Mm-hmm. And we have Andrea with us as well. Andrea, can you introduce yourself, please?
Yes, I'm Andrea. I'm a speech and language pathologist, and I've been in home health for the last 2 years of my career.
Well, thank you all for joining me and contributing to the conversation today. So the first thing I kind of want to start off with is the low-hanging fruit. Let's start with as a physical therapist, let's start with the physical therapist in the group here. So Celeste, I know you're involved a lot with a lot of the PDGM stuff that's coming up, with the practice committee and everything. So I know you've looked at this information from different angles and has voiced some of the concerns and some of the misinformation that's out there. But if we're looking at from an interdisciplinary approach to management of meds, and I know I said M2020 for oral meds, but we can also think about injectable meds as well. Outside of just the taking the pill, putting it in your mouth and swallowing it, can you tell me what your perspective on for a physical therapist brings to the table to M2020?
Well, there's several different aspects. I mean, besides the physical ability to be able to get up out of your chair, walk with or without assistive device, get your water, get your medication, or load your insulin syringe. We also monitor for the effects of the medications. It's important for us to look at more than just taking your medication, what you have available, what you have in your hand. There's just a lot more involved than just having your medications.
Which also affects that measure as well, especially that measure M2020 is a big indicator of what we would perceive as value, especially when it's in value-based purchasing and 5-star values and everything like that. So, the ability to be able to get up and get to your medications will affect that as well, and especially the outcomes of your patients. Lisa, so if I can get up and get my medications, is that where OT kind of takes over at that point, or what else can OT bring outside of just getting the pill to your mat?
You have to look at a lot of things, Troy. I think, when we're looking at older adults, we have to first understand that they use more medications than the average population, and often it's multiple medications. So as an OT, personally, I might look at low vision. Can they see their pills? Can they identify them? Can they identify one pill from another pill? Can they read the directions? Or maybe possibly, looking at fine motor skills. Can they open the pill containers? Can they manage, working with the insulin pump or whatever they need? I mean, being able to break those skills down to a level that we, as OTs, we look at different things like that. So, and then also, of course, cognitive issues, even sequencing, looking at sequencing or refilling their medications, just a lot of various things like that. So at least my solution when I'm working with any of the older adults, I always think about medications as part of my discharge plan. So I start with that from the very beginning. So, and also too, if we have falls in the home or something like that, then we're looking at, well, why are they falling? So OTs have a role in that as well, as long with, with PTs and speech therapists. So that's where you have that interdisciplinary care is in that kind of setting. So I can name other stuff we do.
I think that's a big one on the falls. Thinking about a perspective and an example that I've seen in real life is I was reviewing a chart, and all of a sudden this patient out of the blue, we've been seeing them for a cert and going into about halfway through the second certification. And for those who aren't in home health, that's about 90 days. Uh-huh. All of a sudden, no falls, and all of a sudden 2-3 falls in the same week. And diving into the chart, what did I find? I found that there was a change in medication, a high risk medication. Mm-hmm. All of a sudden, unfortunately, it was an OTA that put it into the chart, but didn't tell anybody else. So unless you were sitting there diving through the chart, no one else was kind of on their radar of this for this patient. It was also a high risk patient at that, CHF, COPD patient, which kind of seems like it's 90% of our patients nowadays anyways, have at least one of those. But, so just coming from that false perspective as a therapist.
And communication, the collaboration between the two. You've got to let other people know what's going on because somebody else might see it where you might not.
And I think we're at a key place to recognize that as people that look at function for our main job, pretty much, you know what I mean? Whether it's walking or whether it's, coordination or whether it's swallowing, just another example, kind of a little bit off topic, but, my father-in-law, just last week started having some changes in his gait pattern and his coordination, and lo and behold, what happened was he had a subdural hematoma, and he had last Friday, my wife spent the whole day in the hospital because he had to have emergency surgery to remove the blood clot that resulted on his brain. So, wow. I mean, that's just a real key, I think, that sometimes we forget about, especially when it comes to therapists and reducing hospitalizations, because we're really the key people that can notice a change in function, because we make them do that, whether you're a PT, OT, or speech therapist. For the most part, you're having them do a lot of different functions in anything you do. So it's really easy to kind of notice that change in baseline for that patient. And as we're talking about, he was another with my father-in-law, he started having a change in cognitive. He started forgetting things, and that was really the big thing that spurred him to actually go to the hospital. He could deal with walking funny for some reason and being real slow, but he started forgetting things, and he was going to Burger King, and he didn't even think about it and just forgot which way to go. And so that spurred him to actually go to the hospital to get it checked out and get an MRI, and that's how they found it. But
I do that.
Well, this is a change of baseline. He started noticing that and the walking. And just it was the memory that kicked him off, though. You know what I mean? And this is a guy that has a very a job where he's a brick mason, so he's really a heavy lifter and a mover. So it's like it was the cognitive part that really got into the hospital. As we think about cognition, that kind of leads me into our speech therapists too. I know we had a whole conversation at one time about how they bring their cognitive abilities to the table as well. They can bring. I was wondering if you would talk a little bit about that, Andrea.
Oh, definitely. I really look at medication management as the ultimate executive function task that our patients have to be able to do. The ability to read the medication label and understand what the directions say. I find that most of my patients are really confused by medications, for example, that they have to take more than once a day. And the way those directions are written is often very difficult for most people to understand. And then to remember from the medication bottle to their medication organizer what they're supposed to do with it, to remember to put it in every day, to go back and not only find errors, but be able to repair those errors. And those are the things that I really look at when I'm doing a medication management assessment.
And it's interesting because I was thinking about this podcast before, because we had some time to think about it. And it's funny that you say that, Andrea, because I got some quotes from some of my patients in the last couple of weeks. And one of them is, I'm taking too many pills right now. I don't even know what I'm taking. I'm supposed to be taking blank, but I don't know if I even am taking that. And then I think these pills are making me sick. So those were some of the quotes that I got from people just in researching and looking at medication management.
Well, and if you look at the orders that people leave, like the skilled nursing, in home health, we get people usually directly out of the skilled nursing facility, and they send them home basically with the MAR. And that MAR is not written for our patients to understand. No. They don't know what TID means, BID, and they need large print. They need dark print. They need the basics of what those are. How many pills? How often? What is it for? Yeah.
I think some of the stuff I've seen that some of the interventions that some of the therapists in the past. And I've seen other ones do it as well as in my toolbox, looking at kind of pill organizers, making like what's it called, pill chart or whatever it is, where you write it out, make sure they know what it is. And color coding their bottles, and there's a lot of leeway with that on color coding, either what it is or when they take it necessarily. And as we look at some of our older adults, even some of the stuff outside of therapy, there's a lot of companies now that are starting to put in, pill packs and stuff like that. And even as those come in, I still think our role is still to help them understand, like you said, like, what are they taking? What are they taking it for? And that way they understand not only the importance, but they can also bring that back to their physician not that we're looking to decrease medications that they need, but making sure that we're not playing the let's just keep adding medication game,
right?
For something that may have resolved or that they're feeling side effects for that they need to switch up.
Well, and some people I've noticed they'll stop taking it, like a diuretic. I mean, everybody knows that Lasix makes you pee, so they won't take it, which, can be harmful. Or they'll have some on hand and say, the doctor 10 years ago said take one when my feet swell. So they'll start taking that without taking their potassium. So, I think it's helpful to get comfortable enough with your patients as well, or have them comfortable enough with you to be able to voice those. Because when you first go in, they're like, they take everything perfectly because they don't want to go back to the nursing home. You don't always get the truth. We spend 45 minutes to an hour with them, so we get a little more as we go. So being aware of those things and the timing of their medication and making sure that they're taking them. And we should be asking every visit. Every discipline should be asking every visit, and then communicating with each other if they're not. If it's something that I can't address when I'm there, maybe Andrea will be there the next time, like, hey, they think that they're taking this diuretic because they have a headache, so just really communicating that and making sure that they're taking them properly.
Yeah, and I think also too, I know when you're looking at an individual taking their medications, if you get to a certain number of medications, and they say that I don't know why the golden number, but it says 5 or more.
Yes.
Then that's when they start really having more difficulty. And
it's because the more medications that you take, the higher chance there is of an interaction between medications.
Yes,
right.
Absolutely.
Yeah.
Mm-hmm.
Well, I think there's an initiative for reducing medications. I think with the CDC, I believe I saw it recently, that they're finally trying to address this, but physicians don't always follow that.
Right. Well, you have, if they go into the hospital also too, a lot of times they get new medications, right?
Oh, yeah.
And then maybe from there they go to a skilled nursing facility. And then from there, it's a very structured environment. Mm-hmm. So the nurses are giving them their medications.
And they're getting perfectly prepared meals.
Exactly. And then they come home, and then it's this, combination of trying to manage all those things. Mm-hmm. So I think, and then also too, a lot of times people take over-the-counter medications that interact with the medications. So, I think the key is for all of us is to ask a lot of questions.
Mm-hmm.
So I think that over-the-counter or the medications that they're at home, I think that's kind of key too, because being in the home, we kind of discover all that stuff that they don't necessarily say because they don't want to in the hospital, but they don't think about it, or it's something they only take every now and then, or they don't think it's, that's just with all the herbal supplements and stuff that's out there, that it's just something that my doctor doesn't care that I take this or that. So, discovering that stuff, what they are actually taking necessarily, as opposed to what it says on the sheet.
Yes.
Yeah.
So true. And I'm sure in home health, I know, oftentimes people have more than one physician, so maybe the cardiologist is, prescribing a certain drug, and then you've got, your primary care. And so then the combination of those different drugs, where the maybe even the physicians aren't talking to each other. Mm-hmm. So I always encourage my patients to bring their medications in with them, in a bag, and pick them up and take them in when you go in, so that the doctor actually can really see what you're taking.
Thank you for listening to the Jaros Health Podcast. Go to jaroshealth.com to get the show notes for this episode and find out how you can join the Jaros community for free. You'll get access to our private Facebook group and the weekly Jaros recap, where we share our favorite reads, podcasts, and any interesting conversations in the Jaros community that week. Once again, that's GEROS health.com. Thanks for listening.